Okay, great. Thank you. So our agenda for today's session is to share with you some of the results of our global stakeholder survey, which many of you would have taken part in. So thank you so much for taking the time to do that. After that, we'll spend about 40 minutes engaging all of you in some discussion about how to translate iCOPE HIV's 3 priorities into action. And then finally, we'll introduce a new call for a steering committee for iCOPE HIV, which we're very excited about. Sorry, my slides are advancing very slowly. There we go. So I'm going to be sharing the results of the iCOPE HIV stakeholder engagement survey. If you have questions during the presentation of the survey, but there's lots of activity in the chat box. So if I miss your question, we can always circle back at the end of the presentation, and I'll try to answer it at that point. Okay, so in terms of the data collection for the survey, we opened the survey on February 2nd, just following our first meeting of iCOPE HIV, and we closed the survey at the end of March on the 26th. So it was open for about 2 months. We did get 192 responses in total, and 177 of those are included in this analysis. The ones that are not included is because respondents indicated where they lived or worked and possibly their role, but they didn't actually answer any of the other survey questions. So we didn't include their responses in the analysis. So in terms of responses by different regions, we did have responses from all global regions. So we had 25 responses from Eastern and Southern Africa, 18 from West and Central Africa, 4 from Eastern Europe and Central Asia, 4 from Latin America and the Caribbean, 2 from the Middle East and North Africa, and a total of 20 from Asia and the Pacific region, and 104 from Western and Central Europe and North America. You can see that for the purposes of the analysis, we did divide those responses into responses that represented respondents in low and middle income settings and those in high income settings. But in the interest of transparency, there are a few misclassifications because I initially did the classifying by region as opposed to by country. So 1 response each from Singapore, Puerto Rico, and Chile were included in the low and middle income group, but should have been in the high income group. And in reverse, 1 response from Turkey was lumped in with the responses from Western and Central European countries as high income, but should not have been classified in that way. And you'll see that the yellow text and the yellow bars in the upcoming graphs are going to represent high income settings, and the red is going to represent low and middle income settings. So the first question that we asked people to respond to was, which of the following best describes their role? So you can see that a vast majority of the people who responded to the survey did indicate that they were either persons or older persons living with HIV, and then a fair number of frontline service providers in community-based organizations. So this is really important to us at iCOPE, being a grassroots organization that we heard from so many people who have lived and living expertise and also work in supporting people with that lived experience. You can see we did also hear from researchers, educators, healthcare providers, and a few others as well. So one of the questions that we asked is whether the unmet needs of older people living with HIV are being discussed where respondents live. And we asked if they're being discussed by 3 stakeholder groups: aging and older people living with HIV themselves, healthcare providers or those who develop clinical recommendations, and decision and policymakers. As you can see from the results, when we look at aging and older people living with HIV and whether they're discussing their unmet needs, about 47% said moderately or a great deal. So that's only half of people are really having these discussions about the unmet needs of the community. When you look at whether these needs are being discussed by healthcare providers and those who make clinical recommendations, about 37% said a moderate amount or a great deal. And then when you look at decision and policymakers, the percentage gets a whole lot worse, with only 17% saying that a moderate amount or a great deal of discussion was occurring. So despite a rapidly aging population of people living with HIV worldwide, the unmet needs of older people living with HIV are still really not on the radar in a lot of places, which is very unfortunate and something iCOPE intends to remedy. So we broke this down to look and see if there were any differences in the amount that these needs were being discussed in high income versus low and middle income settings. And we kind of see a bit of an opposite pattern in this chart about discussion among aging and older people. So about 58% of aging and older adults are talking about their unmet needs in high income settings, whereas only about 23% are talking about those unmet needs in low and middle income settings. Partially, this makes sense because the population of people living with HIV is older in high income settings. So aging related needs might be more pressing and a more kind of high level or top of mind discussion. When we look at healthcare providers and whether they're discussing these unmet needs across the regions, you can see kind of a similar pattern to the one we saw on the previous slide. There is more conversation happening among healthcare providers in high income settings, but it's still less than 50% of healthcare providers who are talking about it, which is a bit of a problem. And then when we look at policymakers and decision makers and the perception of whether they're talking about these unmet needs, the overarching observation here is that respondents think there's very little discussion of these needs happening among policymakers in all jurisdictions. And this is very problematic, given that it indicates poor preparedness to implement upstream approaches that can mitigate the factors that are contributing to these unmet needs. So this is definitely a priority of iCOPE, is to get this topic on the radar of decision and policymakers. So as we move to the next slide, we asked whether the health and psychosocial needs of older people living with HIV are being met where people live. And overarchingly, respondents said they're not. Only 17% of all respondents agreed that these needs were being met. And that's really a very poor percentage. Over 50% of respondents actively disagreed that these needs were being met. When we look at these numbers by region, we actually don't see much difference. The proportion of respondents who disagree that the needs of older people are being met is 50% or more in both low and middle income settings and high income settings. And the proportion who agree that the needs are being met is less than 20% across all settings. So really, these needs are not perceived as being met well anywhere. We also ask respondents to think about where they live. How aware are people living with HIV about developing aging-related health complications, whether those are comorbidities, cognitive impairment, frailty, disability, etc. And we can see that most of the respondents kind of fell into the middle area with a slight to moderate awareness of their risk of developing aging-related health complications. And that indicates that there's room for significantly more education about these risks to enable people to make informed health decisions. When we look at the low and middle income versus high income countries, you can see that there's a perception of greater awareness of these risks among people living with HIV in high income countries as compared to low and middle income countries. But still, only 44% of respondents in those high income settings indicate having either a moderate or extreme level of awareness. That's still relatively low. So there is more room to be doing education across the board. So we also asked an open-ended question about what people felt was the most significant need facing older people living with HIV in their region. And the data that was provided here was so rich, we coded the responses to organize them into themes. And we then put them into this word cloud. So for those of you who aren't familiar with this type of data representation, the bigger the word in the cloud, the more responses it represents. So in other words, bigger words are major themes. As you can see, comorbidities, isolation and stigma, and social determinants like housing and finances figured very prominently in terms of the responses. So I'll break this down. We organized the themes that we heard about according to the iCOPE HIV priorities of care, quality of life, and empowerment. So with respect to care, there were comments about a lack of particular services, for example, tailored care for older people living with HIV, or a lack of appropriate models of service delivery, for example, culturally competent care. Respondents also described facing barriers to accessing existing services that people not living with HIV might be able to use more readily. There were a lot of concerns about care quality, whether providers were knowledgeable about HIV and aging, whether care was being provided in a comprehensive or an integrated way across providers, and unmet needs for care focused on comorbidities were very prevalent in the responses. So including prevention, screening, and management of comorbidities, there was a lot of feeling like those needs were being unmet. And in the bubbles here, you just see some of the responses from our survey participants. So as we go to those themes that we classified under quality of life, respondents identified experiences of disability and feeling poorly because of mental health problems, which were which is a very strong and key theme: pain, sleep, other factors that were making their lives less tolerable and less pleasant. Respondents commonly mention worries about having adequate resources for aging well, including money, food, affordable health services, and housing. And interestingly, these kind of unmet basic needs were seen across both high and low and middle income settings, which definitely indicates that access to resources at the country level does not necessarily trickle down to access to resources at the individual level. Other key themes affecting quality of life that came through very, very strongly were social isolation, loneliness, and stigma. And then in terms of the iCOPE priority of empowerment, weird, something's happening. Oh, there you go. There were a few different issues mentioned. So lack of education and information was prominent. People were feeling like they couldn't always get answers to their questions, but also people talked about feeling invisible as older people, and that signals perceptions of ageism and kind of being overlooked in the broader response to HIV. or health in general. So we ask respondents to indicate which of iCOPE's 3 proposed objectives should be given the highest priority. Well, the results show that respondents preferred objective 1, which was focused on increasing the capacity of decision makers to implement comprehensive models of care, and objective 3, which was about increasing knowledge of aging-related health issues and their management among older people living with HIV. We have a feeling that the fact that objective 2, documenting priority issues affecting quality of life, wasn't deprioritized because it was worded as an activity rather than an objective towards improving quality of life for aging and older people living with HIV. So we're taking this response with a slight grain of salt because we think that quality of life is a fairly pressing issue as per some of our open-ended survey responses. And when we look at the objectives that were shared by respondents in different resource settings, the priorities were very similar across low and middle income versus high income settings. So you can see here, we ask people to rate the following topics as high, moderate, or low priority for education, information, and learning. And you can see that those topics that were rated as very high priority by respondents were mental and emotional well-being, aging-related comorbidities, loneliness and social isolation, advocacy and policy change, and cognitive health problems and management strategies. But right behind those, of course, were some other really important issues around sharing HIV and aging programs and lessons learned from around the world, and housing in terms of long-term care, retirement homes, etc. And just because things like sexual health were rated as less often as high priority, none of the issues were actually rated as not being important. It was just a matter of people indicating what was perhaps most pressing or most top of mind for them. When we asked about preferred methods of interaction with iCOPE HIV, a lot of people said that they preferred these kind of interactive live webinars. So here we are, plus regular emails from us. About 50% said they would like to see a website, and 40 some odd percent said social media, and the majority of those said Facebook would be their priority. So when we ask people about their preferred methods of learning, again, live webinars were preferred by most people. More interactive, more opportunities for discussion. Reports on best and promising practices also rated quite highly. And around half of respondents preferred things like social media discussions, watching recorded webinars, seeing summaries of research, seeing a website, maybe slightly less interactive means of engagement. And very few of you want to see reference lists, but that doesn't surprise me in the least. So that is the results of the survey. I wonder if anyone has any questions about the findings, or whether those questions might kind of arise naturally in our next discussion, which is about how we translate iCOPE HIV's priorities into action. And each of our presenters that's going to facilitate the 3 topic areas for discussion is going to refer back to some of the survey data. So unless there are pressing questions, in which case I would ask you to raise your hand so I can see you, then I will invite Anton, who is going to cover our first priority area, to speak.
Thanks, Kate, but I see in chat one question. Should we answer it now? Yeah. How we manage this?
Yeah, thanks for that question. So The question is, did we divide up the findings based on who the responses were? And the answer is no, we haven't done that yet, but we absolutely could. And there's definitely room for more analysis of the data. So thanks for bringing that up. Where will these results be posted? So we'll be sharing this slide deck and also the recording of this webinar, and we'll make sure that you have links to where you can find that. We'll probably also eventually be writing up the results as more of a report, but we have to do one thing at a time. So we'll make sure you know about it when those documents become available. Any other questions? Yeah, so just an observation in the chat that given the data, it appears policymakers are not putting weight on the needs of people, older people living with HIV. And that is exactly what Anton is going to talk about next. Does the length of time living with HIV need to be factored in? Tez, thanks for your question. Probably yes. The short answer is we didn't collect that information from survey respondents because we were really just trying to get an overall picture of the global priorities, and we weren't limiting the survey to people living with HIV. But in future, I think that's definitely a worthwhile thing to explore. Okay, Anton, I'm going to turn the floor over to you.
Thanks a lot, Kate. Yeah, it was really interesting. I could see in chat some messages like we are talking about aging and HIV since 2000. Actually, in 2000, I still didn't have my HIV. I'm just 43 and been diagnosed in 2003. So I had all chances not to be positive if I knew or if I had proper access as a person who inject drugs to life-saving harm reduction programs and proper prevention programs at that time. But since then, as I mentioned, from 2003, I'm living with HIV. I've been diagnosed, so it's 20 years this year. I'm celebrating living with this amazing disease. Of course, for me personally and for us in iCOPE HIV, that's exactly what we are aiming to do. It's really transform all these, you know, theoretical or tokenistic things to real action. It's really time to act, and I know it from my experience as well as a representative of the community, not only people living with HIV, but people who use drugs. And that's why I think it's always when we, before we open discussions based on certain priorities identified from the survey, I think it's always good to imagine and to bring some personal picture of, let's say, conditional man of 40 plus years old living with HIV. What this person, this man could feel, why it is important to speak about things like a capacity among decision makers. So what is really important for me personally, it's of course change of the public policy to have enough attention to aging in HIV. Because for instance, I'm from Ukraine. It's a lower middle income country, and even now, according to the law, HIV, people living with HIV, they are criminalized. I mean, there is certain criminal code, article in criminal code about the transmission of HIV, as well as other key populations like people who inject drugs, who are still people who use drugs, who are still criminalized. So of course, the topic of HIV as such, I'm not even saying about specific like older or aging people with HIV or older people living with HIV, like people living with HIV, you know, this topic was out of attention for many years among policymakers. Or out of proper resources or needs, but mostly when it's coming, even if there are certain enthusiastic doctors on the ground who want to pay attention to these things or realize that this population needs certain attention. They always bumping into what? Into the absence of, I don't know, Ministry of Health order or certain national, I don't know, strategic document, which really creates this framework of specific attention to a certain population. Or budget limitations, etc., etc. That's why, for me, changing public policy to have enough attention to aging and HIV is, of course, first-line priority, as well as changing community and clinical practice to implement models of care for aging older people living with HIV. Why? Because even if you, in my experience in countries of Eastern Europe, Central Asia, clearly says that even if you have certain law or Ministry of Health Act or some strategic, I don't know, framework of a document, when it's coming from national to local level, municipalities, provinces, or separate certain healthcare facility, it absolutely doesn't mean that it will be automatically transformed to real clinical practice for people. So at least that's the reality of the region and country from where I'm from. So that is why it's always creating the needs of certain advocacy and action, not only in changing legal framework, for instance, or changing policies, as we say, but also then pushing these policy changes to the practical level. So it can be, you know, education of certain education events for certain medical personnel or chief doctors of clinics, whatever, or specific health departments on the municipal level. As well as when you are 40 plus and you know you're living with HIV 20 years, for instance, of course you and you know something about aging and HIV and older people living with HIV, but of course you understand that you still have certain time or age, I don't know, which I mean certain time to prevent many things which we know would have higher risk, I don't know, after 50 or 60, but at least as for now, even with all that additional health issues I already have, like polyneuropathy or other things, but still there are a number of things which can be prevented. And of course, to do that, we should really advocate for prioritization of prevention-based model of care. So not just ad hoc situative needs when you are already 50, 60 plus with a number of different serious health issues you received as you contracted or received, you know, as a person living with HIV in this age, and you already, you know, coming to the doctor and saying, please help me, give me some pill or something like that. But no, I mean, prevention is always better than treatment, then, you know. So that is why any kind of activities in this area is valid to my mind. And as you can see, of course, thanks, Kate, as you can see, advocacy and policy change is in top 5 of areas prioritized by the respondents of the survey. So with this introduction, and yeah, so also you can see different unmet needs, which are best addressed upstream through government or organizational policy change, which is like on the service availability and access and quality areas, as well as access to resources for health. But, and next. Yes, and on this point, I would like to open the discussion. What kind of activities could iCOPE HIV do to help build decision maker capacity to implement comprehensive models of care for older people living with HIV based on best and promising practices? So how do you see these priorities and how do you see these activities?
And just as a reminder to everyone, you can either share ideas in the chat box, or if you want to raise your hand, then we can call on you to share your response verbally if you like. And this is your chance to contribute. So please
I
speak
see
up.
Jeff Berry. I see Jeff Berry's hand.
Yeah, hi, thank you, Anton, and thanks for that great summary. So I'm wondering if there's been any cost analysis or modeling done on HIV and aging, people living longer, if it could present it as a way to save money to policymakers and decision makers, that's going to catch their attention. And so people are living longer. So you would think that medical care might increase because they're living longer. But if we can prevent, I know there's been modeling done on, prevention versus treatment, which you mentioned. It's much cheaper and more cost effective to prevent HIV overall than to have someone on lifetime treatment. And I'm wondering if it would be, if there's been any kind of modeling done on people who are aging with HIV and the cost savings that might be realized if we were to prevent, like, say, certain comorbidities.
So let me just take a stab at that. Thanks for raising the question, Jeff. That's a great question and it's a great point. There is data coming out of Giovanni in Italy showing that the costs for older people regarding the additional comorbidities and medications, that the cost for people with HIV is increased by 40%. So we know there's a lot of extra costs, but I don't think, and I don't know of any study that's been done to show the cost savings that we could have if we have prevention models of care to try and address them before they happen, the comorbidities and so forth. So I think that's a great idea for us to think about.
Thank you.
I see there are a number of things in chat, number of really valid comments. But should we, and I see the hand from Marie-Josée Bouillet.
Yes, Marie-Josée from Montreal. Thank you very much for sharing your thoughts. You put emphasis on the prevention, and I certainly agree with you. Some of the prevention, especially given the high rate of people who are concerned about mental health conditions. I'm an HIV psychiatrist. Some of the prevention is biomedical, but also some of the prevention is psychosocial or behavioral measures. And what part do you think belongs or is best done in the medical setting versus is there a part of it that is best done in the community setting? I would like to hear your thoughts on that.
If you're asking my personal thoughts, that, and again, based on my experience and my observations, of course, I think that mental health or psychosocial needs is always better done or covered by community or, community-led organizations, community level, let's say, peer workers, etc., etc. When it's coming to certain biomedical interventions, I don't know, prevention of certain cardiovascular things with a certain medications, or let's say really clinics-based interventions, that's of course where medical personnel is leading. But I agree, mental health first, because anyway, it's really mental health issues really covering like both sides of an issue. If it's so first line priority, so if it's not resolved, then person even would not go to get biomedical things, would not reach out. I mean, not being having depressive disorders or being isolated. So they will not even try to reach out to some healthcare facilities to get access to certain biomedical things. Yeah. At the same time, even if they are in biomedical interventions somewhere, it's impossible to to help with one issue but not covering or at least not evaluating other issues like mental health. So yeah, that's why I don't know, at least for people from European and Central Asian region, recently there have been launched HIV and mental health platform, which is like a specific communications channel, forum area, and library of special resources, specifically focusing on HIV and mental health. I don't know. I can put in chat this link. Someone would be interested to use it as well.
Thank you.
Thanks.
Thank you very much.
So I'd like to address that, Dr. Brule. Of course, I think that what is called for here is a response by both the community and the medical community. And I think that both can bear a burden here or a responsibility to address the problem, and that both can contribute to the health. So I'm mental health. So I'm here based in New York City, which ought to be one of the epicenters for good health care for people with HIV. And everybody knows that accessing care and services for mental health is almost impossible for people with HIV to get in New York City. Part of it is because the healthcare system for HIV is completely overwhelmed. The clinics are overwhelmed. The reimbursement for mental health care services are almost zero. So I think there's a role for community and the medical establishment and for policymakers to address the problem. And we need policymakers and reimbursement and insurance to address this and allow community and medical care providers to provide better options. And I think one of the things that that Anton mentioned is perhaps a broad opportunity to participate in mental health discussion groups. We just don't have that. So that's my thought on that. Thank you for raising the issue.
Thank you. And I see the hand in Dean Barron.
Hello, my name's Dean. I'm an older person living with HIV in Toronto. I want to focus on the discussion question, which is what activities could iCOPE HIV do to help build decision maker capacity? What's a decision maker?
Really good question. I think when we're talking about decision makers, it's really wide context of people. It can be any person whose decision influencing the lives of older people living with HIV, starting from chief doctor of certain healthcare facility, for instance, if this chief doctor or director of this clinic forming the policy and making the decisions on the level of certain, I don't know whether it's aid center, because it really differs, varies from country to country and region to region how this health system organized, or Minister of Health or Public Health Center Director, or I don't know, members of Parliament when it's coming to certain I don't know, laws or so. So it's really wide variety of people, but in general, anyone whose decision influencing my life, let's say.
So what I'm getting from that answer, and that's a great answer, is essentially you're talking about policymakers who influences policy, not individual decisions or choices for a person. The second one is...
Well, if I could add to that, I'm based here in the US, and I think, let's be clear about this, because, you know, I work a lot, this is Jules, I work a lot on trying to implement models of care for better care for older people with HIV here in New York and nationally all over the country. And nothing is done without funding, okay? To implement good models of care for aging people in clinics, they won't do it essentially without money and funding because they're all overburdened and underfunded. And the only place that money comes from are state and federal and city officials from high up. And essentially it comes from the federal government. So I think when I think about who are those decision makers that pull the ultimate string, it's putting pressure on the high-end decision makers here in the US at the federal, state, and city level.
So it's a high-end policymaker. But the second point is about capacity. Is it just capacity that you're trying to influence or focus? Because I may have the capacity, but I don't focus on this issue. And so my question is, does iCOPE HIV want to change the focus of decision-making and policy, which may include an increase of capacity, but doesn't necessarily have to?
You need both. You can't have, you can't do any of that without funding. So you need funding to expand capacity, but funding needs to be tied to focus. We can't give money to any clinic unless it's tied to a focus on aging issues and clinic care.
Yeah, and I think it's just a matter of wording. I agree that we actually should cover both, like capacity building and focus. Yeah, but also with this point of funding, I would like to add one important additional point where the community representatives of older people living with HIV is in the decision-making process, because nothing about us without us. It's a very valid principle, and especially when it's coming about funding, it's not just, you know, just give us funding, but then to monitor, to have this government or whoever this resource provider, money provider, to keep them accountable. Like I see there is here as many people from, I don't know, Northern America, or maybe from countries which are non-global fund implementing countries, but you know, global funds to fight HIV, AIDS, tuberculosis, and malaria, which is granting 117 countries around the world, and like saved up to 50 million lives so far, according to latest report. But in every country, there is a certain CCM, country coordination mechanism, under the Ministry of Health or Cabinet of Ministers, where communities should have a seat to influence this disbursement of this funding, and then monitoring how it's programmatically implemented on the level of this allocation and implementation. So that's maybe additional point for the discussions, so how we see ourselves as a community in the decision-making process. It's not just capacity building of decision makers. But I see hands of, it was David Martin first, and then Melanie, and then Moses.
Hi, Anton and everyone. I'm so glad to be here and see several familiar faces. I'm in New York. I'm on the New York Health and Human Services Planning Council. I'm a consumer at large, and also SAGE Positive program coordinator for SAGE USA. And I want to really address what was just said about the decision maker capacities, because I think we need to put the decision making back into the client's hands. It's our power that we have, and that no one will get paid unless the patients are there, unless the clients are there. And so I just want to use the anecdote. There's a New York Times best-selling author named Malcolm Gladwell. He has a book called The Outliers, and he speaks to how to become a master at anything, you have to invest 10,000 hours in doing so. So I kind of calculated how long I've been positive, which is over 35 years. And I have over a quarter million hours doing this. So I think the knowledge I have, lived experience I have, is prominent in what the decision makers should be listening to. I think the activities that should be fostered are those that empower the patients, empower the clients, have self-management. There's so much the patient can do that for themselves, to live better, to eat better, to manage their stress, to manage all the things that we can do individually, as well as create the firestorm. It was done. Jules knows it. ACT UP. In the beginning, it was all done with the power of the patients and the community. So that would be one of the activities, or several of the activities, that I would encourage iCOPE to focus on, is empowering the patients, self-management, taking your power back. The doctors can't do anything without the agreement of the patient. So agree to take your medication, agree to come and tell them what's wrong with you, agree to follow their prescriptions. So that's where I would like rest my case with. Focus on the patients and their power to do what you want them to do and do what they can do for themselves.
Let me just respond, because, I know David, this is Jules, we're both in New York, and we work together, and everything David said is 110% correct. And that's what iCOPE hopes to do, to empower people with HIV to do all this. Nothing will change unless we, the community, the advocates, make it happen. They won't do it. They won't do it unless we make them do it. And personal empowerment and advocacy for yourself and for your community is everything, just as David said.
Thank Jules. I think we have a little bit speed up because we still have other panels and other discussions. I still have hands from Melanie. Melanie, please, Moses, and then Nicoletta, but maybe very, very quick if it's possible.
Yes, I agree with David, that self-empowerment and capacity building for people living with HIV, for themselves and their healthcare, but we also have to be, the capacity needs to be built for us to be courageous, brave enough, and able to be at decision-making tables. We have to take care of our health. We have to help other community members take care of their health, but we have got to be at the decision-making tables, and they've got to listen to us. I have been to thousands of listening sessions. They take down copious notes, and then nothing comes from it. We need to be implementing and be in their faces, because we've been discussing aging and HIV since 2000. Okay, I'm an executive director of Older Women Embracing Life, and our group started because older women couldn't find support in the community for them, and so I believe there needs to be. I'm already doing it, but I can't be the only one. Jules can't be the only one. David can't be the only one. We have to build the community's capacity to be at the tables.
Thanks, Melanie. Thanks.
Correct.
So critical.
Anton,
Yep,
can I make a
yeah.
suggestion? Because
Yeah.
a lot of the comments are also focusing on the next two action items and objectives.
Yeah.
So I think maybe why don't we let Jules do his quick overview and Axel, and then we can just open up the discussion
Discussions
on all
for
of,
all. Exactly.
yeah.
Yeah.
Okay,
Thanks a lot.
so
Thanks,
Jules,
yeah.
that's over to you.
Yeah, but please, those who raised hands, please keep your hands, because I'm pretty sure that your questions will still be relevant. Or just raise it again, Moses, Nicoletta, because you were next. But we really a bit out of time.
Over to you, Jules.
Okay, thank you. Thanks for a great discussion so far. And yes, that's what iCOPE and us founders at iCOPE have been dedicated to all along. We wanted to hear it from all of you that we must create a way for the community to be at the table and to have influence. Nothing will happen without the community. The community makes everything happen. It's your voices. It's the voices of people with HIV that make everything happen, and always has been that way. And we wouldn't have had the changes for aging and HIV that we have had without people with HIV voicing and placing demands on government people. So I'm going to talk about quality of life. And I want to hear from all of you after my brief introduction, what it means to you, quality of life. What are your priorities for quality of life? And just to sort of set the table, I'm going to tell you a little bit about me and what quality of life means to me. What's left of it, okay? As a 73-year-old man, a person with HIV for 70 years, my needs have changed drastically over the years. transitioning from being younger in my 40s to into my 50s to into my 60s and into now my 70s. And so my priorities for quality of life today are better healthcare. So, you know, a lot of people talk about stigma and discrimination. And of course, we all face stigma and discrimination because of who we are, social determinants of health, and because we have HIV. But you know what? Those things don't matter to me anymore if I can't get good health care. If I'm going to die because I'm having a heart attack or I have a fracture and I get good care, that stigma, my concern about stigma no longer matters to me. I need and must have the best health care I can get. I must have a better relationship with my doctor, with the clinic. We need integrated geriatric care in the clinics. We do not have that. What we have in New York City and in many places all over the country is this 20-minute visit where you go in and you get a 15, 20-minute visit with your doctor, and that's it. And the care coordination is so limited between your HIV doctor and the specialist that they hardly talk and they don't communicate with you very well, and you fall between the cracks. We need to change that. And that's the highest priority, because without that, I won't remain healthy, I won't be able to function, and I will die. I personally have numerous comorbidities that have mostly developed into my 60s and 70s. And I have developed my own network of specialists over the years. I have my own cardiologist, my own liver and kidney experts, my own vascular surgeon, because I have peripheral artery disease. I have diabetes. I have my own diabetes doctor. I have my own dermatologist, skin doctor. I have my own mental health doctor. I have my own dentist. I also have my own ophthalmologist, my own eye doctor. So I have developed my own network of specialists, not due to my HIV doctor's support, but I did it on my own because I knew what I needed. And I know many people don't know what they need. So that's what education is about, to try and help people understand what they need so they know what they're getting or not getting from their clinic and clinician, so they can demand that this is what they need and want. So I want, and I don't have good relationship with my doctors or my clinics. That 20-minute visit is just a nightmare for me and for many other people. The problem is a lot of people don't realize that they're supposed to be getting better care. They think what they're getting is what they're supposed to be getting. No, that's not the case. So a lot of people don't realize they should be getting better care and they're satisfied, but you should not be satisfied. So it's very important to remain educated and up to date about each health comorbidity, educated about what is heart disease, what is liver disease, what is peripheral artery disease, what is cognitive impairment, what is diabetes, and how can I prevent them? What is good care for that, and what should my doctor be doing? Number 3, better physical function. So I've been disabled for 7 years. For 7 years, I've been unable to function physically. I can't get around. I'm accompanied to all my doctor visits by my wife because I can't go there by myself. So physical function, without physical and mental function, you have nothing, okay? And that's what a lot of people in their 70s are facing and what they're experiencing. They're disabled, they do not have normal physical functioning. Trying to sustain mental health is critical. If you can't sustain your mental health, then you're in just as bad a shape without physical function. So emotional stress, anxiety, depression, I face all of that. I have to deal with all of that on a daily basis with very little support, although I do have a mental health support care person who I speak to. Most people don't, and it's really not enough, frankly. We need a lot more in this system for everybody to have. Social engagement is critical. I lack that. Most people lack that. I think it's important for people to try to enjoy themselves as much as possible. Try to do what makes you happy. Try to figure out what makes you happy. And I try not to worry as much about stigma and discrimination, as I mentioned, because for me, my personal health and my functioning is more important, although stigma and discrimination are part of all of this. And I worry about my future. What will happen to me if I become incapacitated? Who will take care of me? I know that the nursing facilities do not provide even decent care for people with HIV in general around the country. So with that, do I have another slide? So this is just to remind you of what you guys said in the polling of what's important to you. And what you said is not that much different than what I said. Isolation, finances. I believe that people with HIV should get financial support more than they get. When you're over 60 and you're physically incapacitated or impaired, I think that we should be providing more financial support, extra stipends for those people. We should be providing better care regarding comorbidities and invisibility. Yes, we all feel invisible because we're being ignored. The problem is being ignored by many stakeholders in the community. And of course, housing is a much bigger deal than people think it is. And so now I'm going to turn the discussion, thanks, Kate, to everybody here for you to mention to us, tell us what you think are your important qualities of life that are important to you and how we can help you develop a systematic approach to improving all of this for everybody. So let's open the microphones, raise your hands and so forth.
Okay, so we have Nicoletta first.
But I think we agreed that we go with
Yeah.
all priorities and then open discuss, because otherwise we will.
Good idea. Good idea. Okay.
But that's what you propose.
Axel's gonna present just the third objective so that then we can open up the discussion to all of them. So keep your hands up. We'll let Axel just introduce the third area and then we'll launch.
Okay, hello everybody. Well, the priority 3 is about, we spoke about already, about knowledge, education, empowerment, and what could we do into action. We hear about the needs, about unmet needs. Comorbidities was mentioned as very important, and the needs, or the unmet needs related to prevention, screening, coping and management. The discussion was about self-management and self-knowledge. Thus, I will present myself as one of a possible in the group of 60 plus, and what were my still unmet needs as 63-year-old man living with HIV for more than 30 years, having also numerous comorbidities starting when I was 50, 55, cardiovascular, arrhythmia, hypertension, and so on. Jules was speaking about I have macular degeneration. I'm suffering a lot actually from neuropathy, including neuropathic pain. And most of those comorbidities were detected by coincidence and were already in a late stage. Thus, there was no way of prevention. I missed all preventing actions and assessments, and I arranged myself visits to the specialists, but much too late, and without coordination or guidance by the HIV center. Thus, therefore, having this experience, my education priorities, and I would like to get that much before and not now, is, for example, understanding the mechanisms behind those comorbidities. If I would have known, for example, that I have a risk of neuropathy, I could search for some preventing action by, for example, improving my lifestyle or other ways like specific physical activities and so on. Since I didn't know about and I was suffering comorbidities without understanding what's behind, obviously my anxiety was increasing. And for example, very recently, I had contacts with my HIV specialist, and suffering for neuropathic pain, I went to a neurologist, and they said that my neuropathy was due to neurotoxic HIV medication from the past. They did not explain that even it could be linked to HIV itself. I got it from a discussion with another physician, which is very knowledgeable in aging and HIV. Thus, they didn't explain me well the situation, and they didn't explain me as well that some comorbidities I have are linked with neurology, and that pain is only one of the elements. Thus, all that said is that they even said me there was nothing to do. Thus, you imagine my anxiety was increasing as well. Thus, and we hear about prevention and the prevention model of care. My major priority is to be educated within a model where prevention is key and a focus. But therefore, I need better educated professionals as well. Not only educating myself, but being in contact with better educated professionals. And therefore, having a model which has an integrated geriatric care as focus in order to prevent frailty which can be physically, but also mental. We spoke about neurocognitive impairment, we spoke about neuropathic pain, peripheral pain. Obviously, that's influencing your frailty. This cannot be done by 2-minute visits. Jules was mentioning that as well. And if now I'm doing all myself, going to one specialist to another, but there is no care coordination. I would like to have a better care coordination. Thus, as educated, up to date, for knowing what is my best way to prevent my loss of quality of life due to those comorbidities, have a better follow-up. And for example, and I'm living in a rich country, Belgium, I don't get my lab results. And I use the same wording as Jules, that I have a medical background, that I'm quite proactive in getting to the specialist, but without really coordination. Thus, I'm still worried about my future to be handicapped. And with the question, who will take care of me? Thus, that's somewhat a situation where a lot of people of 60 plus are facing the same problems, I think. So those slides this slide was mentioned a few times about the need for information, learning, and education. And obviously, the question is, what could we do from iCOPE to tackle those major needs? And the idea behind the discussion would be, what activities could iCOPE HIV do to increase knowledge? And I would say, not only knowledge, education, empowerment, self-management, to address those high priority topics, which are mental, but also linked to comorbidities, very diverse, but those are mentioned as the major ones. Should we do it through classical webinars, live webinars, but we hear about the needs of education also other ways, like maybe regular emails or reports or informal discussions does the discussion would be what would be due in first step, what should be the development of our educational tools. That would be the discussion.
Okay. So thanks, Axel and Jules. So let's just open up the discussion now to ideas around action steps we could take across all of these priorities. So whether it's influencing policy, improving quality of life, or education and empowerment. There's lots of people who've been waiting patiently to say something. I think actually Moises was first. So Moises, will go to you and then we'll go in order down the list.
Yes, thank you. I'm so excited and happy to be here. And thank you for the organizers. I just wanted to make a couple of comments and share some ideas based on work that has been done here in the States around influencing policy and working with, government agency. Like it or not, we have to work with the governments that are the ones that develop the infrastructure and the funding for systems like the Ryan White care system in the States, and et cetera, et cetera, et cetera. SAMHSA that deal with mental health grants and programs. And, the way we have, at least from the experience that we're doing here, is there was a need to, raise awareness among the people, HIV professionals that were working or are working in policy issues. One thing that we did was we solicited from them that we wanted to create an aging working group. The name of the coalition is called FAP, is the Federal AIDS Policy Partnership, and since 2002 they have been coordinating as a coalition all the important issues related to advocating legislature, but also the Congress and the federal agencies. So we were able to create that aging working group in a process to first educate the policy, the people that are involved and affecting policy directly, but also to put ourselves in that table. And, Jules and myself are the co-chairs of this working group. And, we have been so far using it, also bringing experts from different federal agencies to provide one-on-one on specific issues that their agencies can work on. The other thing that we've done is we have created a cohort of 50 plus people at MMAC. And since 2016, we have provided scholarship to 50 individuals over 50 living with HIV to come to our national conference and starting there, have a whole year of education and training and, community building. Community building has been crucial. So we have provided the environment for these individuals to start building the network, the knowledge, and the community force that is needed for this, like you all well have explained. The other thing was, if government officials, reach out to them, remind them about aging all the time. Any meeting that you are related to whatever, HIV prevention, housing, we need to bring that issue up. We also had 2 listening sessions with HRSA, which is the agency that take care of healthcare, and also with the aging administration part of the federal HHS agencies. So what we're very clear that we need to establish these dialogues. Like, for example, Jules and a group of us always also meet with the National Institute of Health, with the Office of AIDS Research, and we keep, I mean, Jules is great at it. He keep like, at it. But we need to understand it's our right. These people deal with public money, and that public money has to do with the taxes that I pay. So I have the right to ask for meetings to whoever, it doesn't matter how high they are in the system. So I just wanted to share those ideas and thoughts. Thank you.
Thanks, Moises. Nicoletta, over to you.
Thank you. No, because I've been waiting so much, it feels like I'm going to say something incredibly profound. But I just want to go back to what has been said in terms of defining quality of life. So I like to say that, first of all, that for me, quality of life would be a quality of life that is not gender neutral, because so far everything that's been discussed has not has not gender, which means that there is no mention of menopause, which is quite significant for us women. There is no mention of discrimination and stigma attached to be an elderly, frail lady, whatever that means in different societal contexts. Older women are still caring for others as well as for themselves. So these are all issues which may feel and seem peripheral. My own experience of living with HIV, I was diagnosed when I was 21, now I'm 61. And in 40 years, clearly I have seen quite a lot of changes as a woman living with HIV, navigating different cultural and geographical settings, because I was born in Italy and I lived in Italy for a while. And then I moved to Scotland 30 years ago, where I'm still living. And aging has different meanings in different cultural and social contexts. And I think it's important that we take that into consideration. So, and another layer that I think we should take into consideration is that class and ethnicity are also very, very important. I am a white middle-class woman. I'm a university professor. I navigate quite a lot of health issues because of comorbidities, but I can access healthcare in a different way than a woman living in Scotland. I'm just stereotyping for reinforcing the argument I want to make. So when we advocates, we talk about healthcare for all, we need to find ways in which the language we use has to be a language that is approachable to everyone, first of all, because it encompasses different experiences. And many of the experiences that I can share here are not the experiences of women who are still silenced because they don't want to share their diagnosis. They're scared of the doctor, because culturally for women, going to the doctor has different meanings in different cultures specifically. And in the interest of time, I have a few other points that I wanted to make. But the other point that for me is very important is, as has been said a few times, that stigma is not a priority, it's not important. I think stigma is very important. I talk as an academic who has been working on stigma and discrimination for 30 years in academia. Stigma is very much what drives laws, which are affecting us in so many different ways. But also because we're aging, we're also experiencing the stigma of being older and elderly people. Society is not made for elderly people. Society is made for young, affluent, able-bodied people. So we are experiencing double stigma than what we could have experienced when we were younger and healthy and fit. Okay, I've spoken too much. Thank you for listening.
If I could just for briefly address what Nicoletta said. The data and the research is clear. Older women with HIV suffer more comorbidities, they have more inflammation, they suffer worse physical function when they get older, and that's clear. And that needs to be addressed, that needs to be changed. And she mentioned menopause. There's a lot of research showing that's probably one of the major contributing factors, is that women with HIV suffer premature menopause, and women with HIV have worse symptoms related to menopause. And that's a major contributor to why women suffer more with aging. And hormone replacement therapy for women is yet to be fully made available for women and discussed very broadly as a way to address this for women. So that's part of the education process that we at iCOPE think should be included in everything we do. Thanks very much for weighing in on this, Nicoletta.
Okay, so we're going to hear from George, and then we'll go to Eric, and then we're going to wrap up the meeting by sharing information on how you can join our steering committee, because you all are sharing such amazing ideas. So George, to you first.
So I came up with what I would want, from listening to this, on looking after, as a person living with HIV and aging myself, what do I need to live? And what would have been nice to have that I don't have access to, or I'd like to have known. And one of the things I came up with is I'm very good at checklists. So it would have been nice if there's sort of this, not a universal checklist, but something that says, okay, so you're aging, and sort of what Nicoletta said, maybe for women, a checklist for women, a checklist for men, a checklist. And that's just to keep us grounded and knowing, have I really looked at that? Have I looked at my eyesight? Have I looked at my hearing? Have I looked at, when was the last time I did that? As someone that's aging, if I don't see something on the list, I might forget, number one. Number two is creating what we have here today, these online groups, both locally, so that we can share ideas, share experiences, share knowledge. I think that's one of the biggest things that we could ever do for each other, is learn from other people's experiences and tricks and tips of the trade, per se. And then globally, so what's happening in my country, what's happening in Europe, what's happening in Asia, what's happening in other countries, and how do they compare? And sometimes it makes me feel a little bit better that maybe I'm being treated a little bit better than before. So am I really that far off versus other people? Or if I see somebody or hear somebody's story, how can I help them with what I've experienced in a different country, maybe? And last thing, sort of getting to Jules' point, is I think it'd be helpful if government implemented in-home support systems where people could come in-home and help people living with HIV who are aging to make sure that they're bathing, making sure that their healthcare needs are met, making sure that, you know, are they eating? Do they have groceries? All just the incidentals. Because if we were moved to housing or moved to old age facilities, I think it would cost the government much more than having somebody come in and checking on this. Not only that, but then it also helps with the loneliness. It helps with all other factors of integrating back into society. But I can still be hiding my HIV status because I'm not outed yet, but I have somebody there that's compassionate and willing to help me. So that's what I'll say quickly.
Thanks,
Great point.
George.
Great point, George.
Okay, Eric, you get the last word for now. Eric Martinez, are you there? Going once, going twice. Eric Martinez, there you are. Hi.
Hi, how are you?
Good.
So, I was having a bit of a technical problem here. Thank you all for sharing your thoughts and bringing into light of quite a few topics and areas that are well needed to have a discussion, especially in our domain. We all live in different parts of the world, and we all have different communities that are impacted in so many different ways. But there is one thing that I could say that is extremely important and which we are doing here, and that is networking. Networking is a key factor when it comes to getting the word out, educating ourselves, educating our brothers and sisters, helping the community to enhance itself to become a better progress compared to what it was yesterday to today. I heard a couple of topics in regards to medical issues that individuals are experiencing, from comorbidities to peripheral neuropathy. A person who's been living myself with HIV for as long as I have, with 30 plus years, and formerly from New York City, worked my way into Florida and felt like I went back in time. But the point is that I had to do something about it. And to make something happen, that means that I had to network, get myself educated, to know my community. And that started also within getting a support group going and continuously trying to impact the community as best as I can to bring out the needs that are well needed within the community that are not showing up on paper. We all have this little habit that we all turn around and say, well, let's do a needs assessment. Let's do a client satisfaction survey. Let's do this, let's do that. We need end results to those surveys. We need to know what to do with those results, and we need to implement those results. If we're just doing them just to make ourselves look good and look what I'm doing over here and what they're doing over there, that does not impact us. That is not helping us. We also need to make sure, as stated earlier, in regards to, as we have here, we have the LTC program, long-term care. Long-term care to me is a key factor when it comes to trying to keep an individual in their home, no matter what health issue they might have. But for someone who's HIV, who is struggling or needing some home assistant, homemaker, or whatever the case might be, it is a key factor. Instead of bringing them into a nursing home or an assisted living, it's a better environment for them. But these are programs that are needed, but they are not well implemented. And at the same time, they are needed to be more proactive in understanding their community. You cannot have somebody being a caseworker who has no experience with HIV, walking into your door and sitting there and just smiling at you, taking notes down. And then when they leave, they say they're going to help you and nothing happens. You're pretty much chasing them down. And that turns me off dramatically, because to me, I'm a very easy person to get along with. But when it comes down to telling me you're going to help me, then help me. You need help? I will do whatever I can to educate or help you however I can. Once again, I don't want to take too much time, but I gratefully appreciate having this discussion with you all. And thank you for inviting me to this. It was a very positive experience. Thank you.
Thank you so much, Eric. So Mario, we're over to you for
Yeah.
this call.
Okay. I'll take it over from here. Hi, everyone. I'll be very brief since we're running out of time. So, well, yes, very great discussions here today. Well, the survey, the results that were presented here today, they are the result of the many voices from all of those who share our same values and concerns. And that can be summed up, in our the three key pillars we've been talking about improved care, optimal quality of life, and empowerment for aging and older people. We, as iCOPE HIV, we're at the moment in which we are reaching out to potential funders who share our same vision and objectives. And at the same time, we acknowledge that we need to start creating a structure that can better reflect our global outreach and respond to criteria of inclusivity and diversity. So today we will be launching a call for steering group members. Next slide. Well, we're aiming at having a steering group composed of 10 to 12 people, ensuring representation from all global regions, and ensuring diversity with respect to gender identity, race, ethnicity, and sexual orientation. And of course, applications from aging and older people living with HIV are strongly recommended. Next slide. And the role of the steering committee will be that of providing guidance to iCOPE HIV's executive committee about strategy, priorities, work plan, and identification of funding opportunity. The committee members will have a 2-year term, and there will be monthly meetings every 2 months. And the work will be on a voluntary basis. Next slide. So it's a brief online application form that will be open from May to the end of June. You can find more detailed information in the application form and the attached steering committee terms of reference. And you can access the application form directly from the link you see in the slide here, and that Kate will be putting also in the chat box now. In any case, we will be disseminating the call further in the coming days. So we encourage those interested to apply and further disseminate within their networks. And next slide. Well, in conclusion, well, time is running out and we are at the end of the webinar, which I hope you have all enjoyed. I wanted to personally thank you all for being here today and having contributed, expressing your different and valuable perspectives. These will be guiding us, of course, like in the past webinar, in our future activities and activities and steps. So before leaving, I wanted to ask you all if you can answer these two last poll questions. First one is already on the screen. So do iCOPE HIV priorities and activities align with your personal and organizational needs and goals? I think we will be getting the results, right, Kate?
That's right. There's still
Yeah.
responses coming in, so I'm just giving
Okay.
it a minute. Okay, so I'm going to close this poll and you can see the results here. Most people feeling like, yes, the priorities are aligning with their own. And I'm going to just launch the second poll in which you have an opportunity to share with us.
It's an open question, right? Yeah.
Yeah, that's right.
So do you have any comments, suggestions that would help us make future iCOPE events better?
And Mario, perhaps we can just leave this one open.
Yes,
Yeah.
sure.
As we wrap up, because people might be busy typing.
Yes, of course. So I would say we can close it here. And
Yep.
so once again, I thank everyone for having attended this meeting, and it was a great meeting, a lot of interaction I've seen. I think we all agree it's been a good meeting.
And over the next few days, I'll follow up with a link to the recording and the slide deck as well.
There's something in the chat saying that the SurveyMonkey link doesn't work. Can you put it in the chat?
Oh, yes, I absolutely can. Just let me close the slides.
Maybe we can resend again afterwards?
Yeah, we can absolutely resend it, but let me just pull it up and put it in the chat room right now.
Well, in any case, all those who have attended today, we can send it back to them as well. Okay.
Okay.
Okay. So thank you all, and have a nice evening, morning, whatever it is.
And just a note to those who signed up for both this meeting and the one that's happening in 12 hours from now, they're going to be the same. So there's no need to come to both unless you really want to. But I know some of you might have just been keeping your options open. For those of us who are in North America, it's at 1 in the morning. So I'm sure some of you will not opt to join at that time.
No.
But if you want to join us a second time, you're always welcome. Thanks, everybody.
Okay. Thanks. Bye-bye.
Thank you very
Bye.
much.
Thank you to everybody.
Ciao, Mario.
Ciao.
Thank
Ciao.
you, Jules. Everyone.
Thanks,
Thank you.
David. Thanks, David.
Bonne
Bye.
soirée.
Bye.
Слава Україні.
Thanks,
Safe
Paris.
Oasis.
Thanks, Eric in Florida.
Thank you so much. Can you guys send me
Bye, everyone.
the link for the steering committee, please? I didn't see
Thanks,
it.
Brenda.
Yes, who's
Thank you.
talking?
It's Eric Martinez.
Yes, Eric. We'll be sending the link out to everyone.
Thank you so much. Appreciate
You're
your time.
welcome. Thank
Bless
you.
Bye-bye
Thanks,
now.
Nicoletta.
Have a good
Thanks.
evening.
Thanks,
Bye.
Nikos. Thanks,
Bye,
Nikos.
everyone.
So Anton, Jules, Axel, and did we lose Mario already?
I think
Thanks,
yes.
Melanie.
He's reflexively.
Bye.
No, but I didn't. You were saying bye. So
No,
I thought
do
I
not
don't know, I
leave.
thought we.
Do not leave.
Oh.
I'll message Mario to come back.
Yeah, we can anyway catch him in 12 hours, I guess.
True.
I'm trying to leave the meeting, but the leave button disappeared.
Do you want me to help you?
Yeah,
I can leave you if you want.
okay, good.
Okay. Bye,
Bye,
Melanie. Thank
Melanie.
you.
Bye.
This was great, though. I really loved it.
Thank you,
Thank you.
Melanie.
Thanks. So Kate, maybe you can help too. Okay.
I am.
Almost. You are.
I have to do it one person at a time.
Right.
Okay, I'm gonna stop the recording firstly.